Thank you very much for this wonderful opportunity to present at this forum. My name is Dr. Mahesh Kappanayil. I do not have any financial disclosures. I come from this center, Amrita Institute of Medical Sciences. It's a large tertiary care pediatric cardiac center from South India. And this is one of the largest pediatric cardiac programs in the country. We operate about 1,000 children with an overall operative mortality of less than 2%. The mortality for the last year was 1.1%. And we are a go-to center for a lot of the complex defects in the region. And we have been using 3D printing and extended reality for planning complex heart surgeries for the last 10 years almost. We set up a 3D printing lab at our center in 2015 and an extended reality lab in the year 2021. And we have been using these technologies extensively. So today we're talking about double outlet ventricles. As we have heard through the morning, this is a spectrum of heterogeneous, spatio-morphologically complex cardiac lesions, which could essentially be of three types as we saw. It could be a double outlet right ventricle, it could be a double outlet left ventricle, or it could even be a double outlet both ventricles. In addition to the ventriculo-arterial abnormalities, connection abnormalities, these patients could also have abnormalities of the cardiac situs in position, veno-atrial, atrioventricular, interventricular relationships, the great artery relationships, and also the presence or absence of outflow obstructions. All of these combine together to basically contribute to the patient's physiology and also the treatment approaches, whether we are taking the biventricular approach or the univentricular pathway. Spatial understanding is extremely important while managing this group of lesions, but it is often lacking because most of us do not have access to morphological specimens during our training years. The cardiac imaging is largely two-dimensional, or even the three-dimensional imaging like CT and MRI are viewed on two-dimensional screens. And we communicate through diagrams and photographs and textual descriptions. And our spatial intelligence is very variable. The way we imagine 3D when we see 2D images or read a text and imagine 3D, this is very, very variable among all people. So virtual reality, can it be a game changer in this? I think yes. Because in virtual reality, what you can potentially do is take the medical scan images, which is the volumetric imaging in the form of CT or MRI, convert them into digital twins, and use them for immersive viewing that could greatly enhance your understanding, your planning, ability to communicate, simulate, and implement digitally planned surgical steps. The process of creating a 3D model is something like this, where we take the raw data of the CT scan or the MRI scan, we do a process called segmentation or volume rendering, and what happens is that the whole 3D model of the heart emerges in front of you like a hologram, and you can interact with it very, very immersively. You could actually take the heart and make it as large as this auditorium, and you can actually take a walk inside. As you can see, I'm entering inside a complex heart here, and I'm taking a look at a really complex VSD from inside of the heart. So this gives you a very powerful visualization and understanding of complex anatomy. And virtual reality can have various digital tools, like you can move and rotate these models, you can change the scale, making it bigger or smaller, you can cut, you can do virtual dissections, you can measure, annotate, and simulate surgical procedures. As you can see here, it's possible to annotate, label various intracardiac structures. This is the regular CT scan of a patient, nothing, no special imaging. And you can do precise measurements in a curvature, in a straight line. You can do simulation of various steps, including the placement of a baffle. So coming to double outlet ventricles, understanding and communicating anatomy with virtual reality, how do we do this? So recently we looked at the 63 cases of double outlet ventricles that underwent a cardiac CT at our institution over the last 7 years. 58 of them were DORV, 3 were DOBV, and 1 was a DOLV. These are all the most complex lesions where we did a CT to understand the anatomy before going to surgery. So the DORV is the most common and the best studied of all the double outlet ventricles. There's this lovely paper from the Toronto group which talked about the essential modifiers, anatomical modifiers of the DORV. The most important modifier that they've described is the outlet septal malalignment. The outlet septum can be malaligned, number one, in a perpendicular fashion. And if the outlet septum is malaligned in a perpendicular fashion in a way that it is attached to the leftward aspect of the ventricular septal defect, as you can see in the cartoon A, then the VSD gets committed to whichever artery is on the right side, which in this case is the aorta. And if the VSD is to the left of the malaligned coronal septum, then the artery on the left is the one that gets committed. And these arteries could either be aorta or pulmonary artery on either side. Here is an example of a virtual dissection of a case where you can see that the outlet septum, which is labeled in red, is malaligned in a perpendicular fashion, and the ventricular septal defect is to the right of the malaligned septum, and the aorta is directly overriding it. So this is a subaortic VSD in the context of perpendicular malalignment of the conal septum. Now, here is another DORV. Here, the VSD is to the left of the malaligned conal septum, and it's the pulmonary artery that is closer in relationship. So this is a perpendicularly malaligned outlet septum with a subpulmonary VSD. The management of each of these lesions would be different. The first one would be like a simple VSD tunneling to the aorta. This one would require a tunneling to the PA and an arterial switch operation. And here you can see that the VSD very clearly is doubly committed. And the outlet septum is sitting right in the middle of the VSD, and both the arteries are equally committed. So you have the option of either doing a Rastelli to the aorta with the resection of the outlet septum, or directing it into the pulmonary artery and doing an arterial switch. The outlet septum could also be malaligned parallel. Now here you can see that the red labeled outlet septum is parallel to the plane of the interventricular septum. When the septum is perpendicular, the arteries are more or less side by side, but when there is a parallel septum, the arteries become anteroposterior. Here you can see that it is the aorta, which is the more posterior artery in closer relationship with the ventricular septal defect. So the physiology would be like a VSD physiology, and the repair would involve routing the LV into the aorta. This, on the contrary, is a parallelly deviated conal septum, as you can see here, but it is the pulmonary artery. In this case, it's a banded pulmonary artery, which is closer to the VSD. And the treatment, the preferred option would be routing this LV into this pulmonary artery and doing an arterial switch operation, as compared to putting a long patch across into the aorta. We also found something which has not particularly been described before, that the deviation of the conal septum is neither perpendicular nor parallel, but is somewhere intermediate. And if this outlet septum is deviated at an angle of more than 45 degrees, it behaves more or like a perpendicular septum, with one of the arteries being on one side and slightly more anterior. In this particular case, this is a subpulmonic VSD, and the aorta is leftward and slightly anterior to the pulmonary artery. And if the outlet septum is more acutely malaligned at less than 45 degrees, it behaves more like a parallel malaligned conal septum, with the arteries being more anteroposterior in this relationship. And you can clearly see that this is the pulmonary artery, which was closer to the plane of the VSD. The ventricular septal defect and the infundibulum also become important determinants. And here you can see a DORV with a very restrictive ventricular septal defect and long infundibuli. So here, if we wanted to repair it, this would require extensive enlargement of this ventricular septal defect and routing into the aorta. So you can make all these plans when you get such kind of immersive visualization of the anatomy. The atrioventricular connections are a very important part of the anatomy, and here this is a DORV with an AV canal defect, and this is a DORV in which there is AV discordance. So this is like a congenitally corrected transposition of great arteries, but both the aorta and the pulmonary artery both arising from the left-sided morphological right ventricle. The ventricular relationships and the adequacy are also very important, and this is a case where you have a supero-inferior ventricles or the upstairs-downstairs ventricles, where the challenge was how do you manage this patient. Managing to see these images in such clarity really helps you make a clear plan of management, as I will show later. And this is a crisscross heart that was discussed in the morning, where the ventricles have been twisted but clockwise, placing the morphological right ventricle on the top and both the great arteries arising from the superiorly located morphological right ventricle with a large inlet VSD which is labeled in orange. The relationship of the great arteries themselves depend upon the malalignment of the atrial of the conal septum, as well as the position and the axis of the heart within the chest. Of the 58 DORVs that we looked at, the VSD location was subpulmonic in 51%, 41% in subaortic, 41% subaortic, and doubly committed in 8%. The outlet septum was parallel malaligned in 41%, perpendicular in 36%, and intermediate in 23% of the patients. How can we use VR to plan the surgery? Here are a few case examples. This is a case of double outlet right ventricle with a double inlet right ventricle. By that, what I mean is you can clearly see the parallel malalignment of the outlet septum, and there was a straddling, grade 2 straddling of the mitral valve chordae into the rightward aspect of the interventricular septum. And here we are deliberating the plan. Should we route the LV into the aorta in this way? We are doing it all in 3D in VR, and or we can direct the LV blood into the pulmonary artery like this, and maybe put a patch that is on the rightward aspect of the straddled mitral valve, in which case we could possibly get a repair. And here we are trying to show how we would potentially place the patch so that the straddling of the AV valve is taken care of. And this is what eventually was done in this patient with an arterial switch operation. This is a double outlet right ventricle with an AV canal defect, as was described by Shiva right now. You can see the grossly dilated aorta completely on the rightward aspect. This is the surgeon's view. The surgeon is getting inside the atrium and looking at what he would see in the surgery. The aorta is in 9 o'clock to 11 o'clock position. He plants the baffle, and this is the kind of the baffle simulation that we prepared for the surgeon to be prepared for this particular surgery. This is a DORV with the upstairs downstairs ventricle. Here the challenge was, would we be able to route the downstairs LV into the aorta that is on the top without obstructing the tricuspid valve inflow? And here we can clearly show with the baffle simulation that this may be achievable, and this is what we actually did in the operating room. A DORV with crisscross ventricles. Here again, we found that this LV was routable into this pulmonary artery, which was right above the VSD, and we planned this surgery down to precision, and this surgery could be executed successfully. These are really complex operations otherwise. This is the double outlet left ventricle. You can see both the great arteries completely from the left ventricle, and double outlet both ventricles, as Dr. Arya explained in the morning so beautifully. You can clearly see the purple shaded outlet septum perpendicular and overriding this blue shaded crest of the interventricular septum, with both the great arteries being committed to both the ventricles. This is the double outlet, both ventricles. Again, you can see the crest of the interventricular septum being overridden by the outlet septum. This is in comparison to a double outlet right ventricle with a doubly committed VST that I showed previously. The double patch technique, as Arya sir told, that would be the probable solution. And here we did a surgical simulation by actually doing a digital resection of the outlet septum and simulating the double patch. We also had a plan B that in case the VSD is too restrictive, we may direct the blood into both the great arteries and then do a Damascus Stansel procedure. This is what was eventually done in this particular patient because the VSD was too restrictive for a double patch technique. In order to implement this digital plan of the baffle planning, what we have been doing recently is 3D printing the baffle designs that we actually created digitally, and then taking into the OR as a baffle template to cut the initial pericardial patch so that the surgeon has less intellectualization to do in the operating room by pre-preparing a patch that can be used for the complex procedure. And over the years, we've been creating an entire morphology library of all kinds of complex disease because we do not have an actual morphology museum, but we have a digital morphology museum. Another very, very powerful and useful way of using VR has been to create instruments of collaboration. We have recently built this platform where we can bring in the surgical the 3D models into a VR space. You can also pull up various imaging data, including the CT scans or the X-rays and echoes, and we can view it in VR, not only by oneself, but you can have multiple people join these sessions from anywhere in the world. Many different countries across the world are participating together as virtual avatars, and we're discussing the planning of a complex surgical case together. And this is the first time that something like this has ever been achieved.
If we were to even route it to the pulmonary artery, because that's also something we must consider, right? So whether whether we need like a 1.5. That's also in the realm of the possibilities, right?
Yeah.
So we did the CAT.
I'll believe it then.
Yeah, so we did a CAT. So can you see this CAT data? I pulled it up as a banner. So the data looked okay for a single ventricle kind of a backup plan, right? Hello?
So you can see that people from across the world are gathered together in a virtual environment, and we are discussing the planning of a really complex case, moving around each other as if we were in a real physical space, looking at the same digital 3D models and simulating the surgeries. So these are very powerful technologies, and it will be possible for all of us from across the world to actually gather together and discuss complex cases together for teaching and training, as well as for actual case management. And we have used these platforms to assist heart surgeries being done in Brazil and Vietnam. Shiva has been part of this particular project, and it is extremely exciting. And we also plan to take these technologies to the theater so that even as the surgeon is operating, we can assist the surgeon. So definitely virtual reality is said to be a game changer in surgical planning of complex congenital heart diseases and particularly of the double outlet ventricles. Thank you very much.